Good morning, everybody. My name's Leo Tutt. I'm the president of MRFI, and it's my privilege to welcome you here today. On behalf of my colleagues at Meniere's Research Funding, I wish to thank you all for coming and to hear from our speakers addressing the most recent advances in the Meniere's disease research. I also want to thank our speakers for making their time to bring us up to date and in their progress they've made in their tireless efforts to seek relief of those, like me, who suffer from the devastating effects of the Meniere's disease. I apologise, I'm having a bad day. Some of you know what that means. I consider myself lucky, actually, because I didn't develop this thing until I was 72, some 8 years ago. And so I was able to carry on a pretty successful life up until that date. So I really struggle to understand how difficult it is for those who connect this disease before they had to finish their working career. And it was that decided we had to find, in my mind, that we have to find a cure as soon as possible. I must say I've been involved for some 6 odd years now, maybe a little longer, through the efforts of the chap who was really incidental in the MRFI, and that's my good friend Bruce. I now will go on with the rest of the speech, which I'm having trouble reading. I'll take this opportunity to recognise my predecessor that I just talked to you about, Bruce Kilpatrick. It was his foresight in establishing the research centre and his very significant financial support that he continues to make, for which I wish to thank Bruce. May I also thank the Whirled Foundation for their support of this symposium, and also the Sydney Cochlear Implant Centre for allowing us the opportunity to use these premises. Finally, I'm sure you would expect me to take this occasion to plead for your further continued financial support. I can assure you that all the money we received is used in research. All the committee are volunteers. We don't receive any financial reward for the work we and they do. I now like to pass over to your well-known and respected Professor Bill Gibson, AO. Thank you, Bill.
Thank you. Thank you. Thank you.
Thank you.
Thank you, Leo, for those words, and thank you everybody for coming and supporting us once a year. This is becoming an annual event, and I always look forward to it because there's always something new that comes up. Now, I'm going to start by just talking about intratympanic therapy for Meniere's disease. It has been going for a while, but it's becoming more and more popular. The middle ear provides a portal for the introduction of medications into the inner ear. So the medications can either go through the round window, does that work? No. Or through the stapes footplate. And then the medication goes directly into the inner ear where the problem is. I did a little study with Alex Saxby, just working out the depth of the middle ear. We found that if we go posteriorly around the rim, we can put the medication in more easily, and we want it to go basically to this part there where it says 83, that's about where we want the fluid to go to get in. So I now put my medication through posteriorly. I used to do it anteriorly, but now posteriorly. So the way we do it is we put a little dot of phenol on the eardrum. Some people use an anesthetic ointment, or EMLA, or you can use phenol. Phenol is very quick. And then the patient has to lie flat so that the stuff from the ear doesn't trickle straight down the tube towards the nose. It's got to stay in the ear to be absorbed into the ear. We use a long spinal needle to inject it. There's a lot of dispute as to how long people have to stay in that position to get the medication into the ear. Some people leave them on their side for an hour, but this paper here at the bottom was saying that after 10 minutes that's about as far as you can expect, unless you keep applying it. So these are two gentlemen that Dan knows very well. Alex Salt, he worked with in Washington in the States, and Stefan Plonky is a German guy that I know well as well. And they worked out the pharmacokinetics, or the principles of how medications can get from your middle ear into your inner ear. And they talk about liberation, absorption, distribution, metabolism, and elimination. Oops, wrong one. So liberation is just when you put the stuff in, it has to come out of whatever the carrier is to be absorbed into the ear. So we're either using a liquid in the middle ear, or some people are using catheters to introduce it, little wicks. They're putting it on pieces of gel foam and sticking it into the ear. And then there's the sustained release, so that you can keep putting the medication into the ear over a longer time. And these are the hydrogels. And more recently, there's things called nanoparticles, which are tiny, tiny things that are so small they can get through the round window membrane, but you can put different drugs onto them, and you can even steer them around magnetically. So when the fluid goes into the middle ear, it has to go from each of the chambers of the inner ear, from the scala vestibuli through the scala media and scala tympani. Now, Alex Salt and Stefan Plonky showed that most of the travel of the stuff inside the ear goes up the spiral ligament, which is the green structure here. That's a guinea pig ear, and you can see that it can go up in towards the vestibule, where the semicircular canals are, or it can go up towards the apex of the ear. Don't like your thing. I'll use the button on the computer. So distributions involves the process by which the drug diffuses or flows within and between the different inner ear compartments, and how far it can spread down the cochlea and into the vestibular portion. Metabolism is when the drug gets converted into either an active form or into compounds which can be eliminated. And then elimination describes the removal of the unchanged drug or metabolite from the inner ear to the bloodstream, or to the CSF, or to the middle ear. So what are the pros of intratympanic treatment? Firstly, you can avoid systemic effects. So if we put steroids into the ear, that doesn't affect the rest of the body, whereas if we give steroids to a diabetic person, it'll upset their diabetes. So it opens the door to use medicines in some people that wouldn't be possible except by putting them in directly. Some of the medications that can be used, or we hope to be used, are not really suitable to be given by mouth or by injection. It's better to put them into the ear. And we can put much larger doses into the middle ear. So we get more into the inner ear than we can even if we give massive doses orally. The cons are that we might damage the eardrum or the middle ear structures. I think that's excessively rare. I can only think of one person in my own series who had a perforation after I'd done about the third injection, and that was easily closed just by scratching the surface. So it's a very safe procedure to put it into the ear. It's impossible really to know how much of the medication is actually getting into the inner ear, no matter how you do it, even with a catheter placed right into the round window membrane. And it is, of course, a one-off treatment if you're injecting rather than a sustained treatment. But maybe the use of these hydrogels, which we can inject into the ear, will allow them to diffuse more slowly over a longer period of time. So we're talking about intratympanic steroids or intratympanic gentamicin. But there will be many other medications which can be given by the intratympanic route. So we're talking about things that they've been trying for to prevent sound damage, like J&K inhibitors, inhibitors of calpain, liquid peroxide, intratympanic delivery of infliximab, which reduces the progressive inflammation of the ear, etc. And ganglicyclovir is an antiviral. So all these things probably will have a future. We haven't used them really in human beings yet, but in animals, the experimentation is going on. In the eyes, the eye surgeons already use an insert, which is called the Vitrasert insert, and they actually stick it in through the sclera into the vitreous humour, and it dissolves over 3 months, and it releases valcyclovir for people that have herpes. I've often wondered whether you could put something similar to that into the round window niche. So intratympanic steroids were first suggested by Sakata and people way back in 1986. And in the paper they wrote, it was concluded from these results that the first choice of therapy for patients with Meniere's disease who should resist to all conservative therapies should be the middle ear steroid infusion therapy at the outpatient clinic. And the second choice would be an inner ear anesthetic therapy, and that both therapies were worthwhile experimenting before considering surgical treatment. This was lidocaine that they put in the ear, and I did put it in one person, and they were violently vertiginous. And I don't think it's a very good idea at all. So, but the first thing that he wrote, obviously, is more sensible. So since then, there's been some very good papers have come out by Lloyd Minor, Jim Carey, well-respected people showing what good stuff dexamethasone can be in the ear. And the last paper I've listed there is really the only double-blind controlled trial, and that showed a positive effect. So there's 2 protocols. You can either use a single dose, or you can give a dose on every day for 5 consecutive days. Some people give doses once a week for the 4 weeks, and then there are people that give a dose every 2 to 3 months to keep the Meniere's at bay. So obviously people don't really like having injections that frequently. So this OTO 104, which some people may have read, was a gel that was developed called Otovidex, and we all thought it was going to be absolutely marvellous. You inject it through the ear, and it solidifies at body temperature around the round window, and then can exude the steroid very slowly into the ear, taking it up 2 to 3 months to finally disappear. Sadly, it failed its trials, and it's been withdrawn from the market, but I think it might come back. So for people who are having a series of attacks, that may well be a good medication. It's not quite available for you yet. So we know that steroids are powerful anti-inflammatories. If you have an inflamed knee or back or whatever, they can inject it, and it stops the inflammation. John Shea was the first to suggest that it was the anti-inflammatory reaction, and he actually suggested it had to work on the endolymphatic sac. So why should steroids affect Meniere's disease? One theory is that they open little channels in the ear called aquaporins. There's several different types of aquaporin, and that allows the fluid to transfer from one compartment to the other. But most people think it's due to it reducing the inflammatory changes in the ear. So we're suggesting that Meniere's, when you get a cluster of attacks, it's an inflammatory change that's occurred. And I think it may also reduce the inflammatory reaction of the endolymphatic sac. So there's a few studies where they have put steroids into the endolymphatic sac itself in humans. One is at Jeff Harris's lab, so that's well thought of, and the other is Kitahara. And they put depomedrol directly into the sac and said that it showed that there was a benefit to the persons that did it. But that does require surgery to get to the human endolymphatic sac. So the possible mechanism, and this is my own view, so this is unproven stuff, is that if an inflammatory event occurs, the endolymphatic sac can produce a substance which actually increases the endolymphatic hydrops and causes an increased flow of endolymph towards the sac to remove the nasty things from the ear. But the compromised inner ear in Meniere's disease cannot handle this increased flow, and the excess fluid then overflows into the vestibular portion, causing the attacks of vertigo. So that's just my theory. We've got research to do to find out exactly where steroids work inside the ear. So the conclusion of steroids was the Cochrane review is a system of where they're really rigid results. They review to make sure it really does stand up to scientific principles. And they came out with the thing that the results of this review are encouraging. However, it's based solely on one single study, which is the double-blind study. And they suggest that more studies are needed. But there are lots of studies, single studies that are not double-blind, that show its efficacy. So my own view, again, is that there is a short-term effect to steroids, even after single-shot delivery, which can stop a cluster of attacks. So if you're having an attack twice a week, you go through a period of a few months where it's happening frequently. In my experience, often a single shot can stop that cluster of attacks occurring. So now I'd like to change the other drug that we use quite frequently, and that's intratympanic gentamicin. It's a very powerful antibiotic. It's given in life-threatening conditions, but it can damage the inner ear. And it's probably the commonest reason why people lose their balance in both their ears after they've had injections. We give it intratympanically, deliberately, to reduce the balance in the ear. So I want you to think of yourself as an aeroplane, and you have a motor on each side, which is your labyrinth, and hopefully you fly along nice and steady and evenly. We're suggesting in Meniere's disease that one of the motors gets hyperexcitable, and it's not working very well, but suddenly it takes off and it gets very excited, and then it spins you around. I hope that didn't upset anybody in the audience. Okay. But the intratympanic gentamicin then reduces the vestibular output, so you can't spin round so much. But there is, of course, the fact that when that happens, to begin with, you feel you're tilting towards the side that received the gentamicin, and you have to learn to re-pilot the plane so that you've got a steady pathway. And everybody can do that. As you get older, it can be helpful to have some physiotherapy to back it up. So what are the pros and cons? See, the alternative's really a labyrinthectomy or a vestibular nerve section. But with intratympanic gentamicin, there's no surgery, no complex surgery. It's just an office procedure. And it can be titrated. So we only have to give enough gentamicin to control the vestibular function so you don't get nasty attacks, we don't necessarily have to destroy the entire balance system in the ear. The againsts are that you can damage the hearing as well. Intratympanic gentamicin in some people seems to have little or no effect, which is very annoying. It can have stronger effect than be expected, and we have to be careful of elderly patients and people with a possible genetic problem. And there are also always the concerns that the other ear might become involved. Possible hearing loss. Because the gentamicin doesn't go right down to the apex of the ear, it tends to hit the high frequencies. So if you look at the audiogram, it's the high-pitched end of this patient where the hearing has been lost. But that's after a lot of gentamicin. Gentamicin can have little or no effect, and one of the reasons may be because you've got an adhesion blocking the middle ear. So sometimes the surgeon has to go in and clear those adhesions before it's possible to apply gentamicin or even steroids. There can also be probably a genetic resistance to gentamicin, but that has not been shown yet. Sometimes it has a stronger effect than expected. So in elderly patients, and that's anybody over the age of 65. That's terrible. It shouldn't be called elderly. But anyway, we do insist that you have your balance tested before we do anything that's destructive like this, because it's somewhat destructive putting gentamicin in the ear. So all the patients, well, I said over 60, have vestibular testing. In fact, I recommend it for anyone who's having gentamicin. And then there's the possible genetic. We know that after intramuscular or intravenous administration, there can be very dramatic changes to the hearing and the balance. And there are reports that a single injection of gentamicin can cause hearing loss in individuals who have a variant in the mitochondrial gene. Aminoglycoside-induced ototoxicity appears to be a genetic susceptibility in some individuals, and there is a mutation which has been shown to be responsible for this in all the familial cases. So they're trying to develop tests to find out if you receive gentamicin, is it going to have too big an effect on you? But I must say it seems to be much rarer with intratympanic gentamicin. If you give it intratympanically, you don't often see this effect. And I've only actually had one case in over 200 patients where one injection really did wipe out all the balance in the ear. And that was an elderly person, unfortunately. Anyway. So there are always the concerns, if you're going to have gentamicin, that the other ear could get affected. And then if you've wiped out the balance on one side, and then the other side gets involved, that will be a problem. So there's two protocols. There's the low-dose protocol, where you only give 1 or 2 doses of gentamicin. And then there's the high-dose protocol, where we try to ablate the balance in the ear, 3 to 4 doses at weekly intervals, or several doses until you prove that the balance has been lost. We used to do a head shaking thing and see if any nystagmus occurred. Single dose is now taken over. It was first reported at the Mayo Clinic with an 84% response rate of vertigo and no change in hearing. And these results were attributed to claims that gentamicin destroys the endolymph secreting dark cells before actually getting rid of the sensory epithelium. So the single dose thing has really taken off. And it's very safe. You know, you're very unlikely to damage the hearing with a single dose. So Jeff Harris and his group did a meta-analysis at all the studies, and they showed that with the titration where you ablate it, they got 81.7% complete control and effective relief in 96.3%, which is very good. But of course, you've left them with no balance on one side. With the low-dose method, there's 8 studies, and there was a 67% complete vertigo control, which I think is excellent, and effective vertigo control in 86.8%. And this is a two-year study, so that's good for 2 years. After that, maybe the figures are worse, I don't know. So my own theory, this is what I do in my own practice. I give one dose initially and wait a month, and I could give a second dose if needed. And I only do the ablative therapy if the attacks continue. Now, the United Kingdom has a Meniere society, like Whirled, and they've stolen our logo, I reckon, Bruce, yeah? And Ben Folan was a young fellow who won the prize, their inaugural Meniere's prize, and he did a postal survey. Now, postal surveys are not very scientific because you don't know the bias of the people that are replying, but it was quite interesting. He said 211 people tried steroid injections and 193 a positive improvement, 65 which reported a good or great improvement or cured symptoms, 59 reported no change in their symptoms, 24 said their steroids make their symptoms worse, that's unfortunate, and the remaining 5 weren't sure. So that's a 58.27 positive improvement with steroid injections. And then he studied 107 people who had tried the gentamicin, and of that 66 reported a positive improvement, and 48 said it was a good or great improvement and cured the symptoms. 21 said no change. 17 people said it made their symptoms worse. The remaining 3 were not sure. So it's a 61.66% positive improvement with gentamicin. Postal surveys obviously are due to bias, but it gives you a rough idea. So all these treatments, some people it's obviously going to suit, some people it's possible they could not help them. You have to be aware of that, and that's why we need much more research. But I think it's promising because in the future I think there may be many different medications that can be given through the ear, avoiding the effects on the rest of your body. And I think we'll see some wonderful new drugs, I hope, in the future for you. Now, thanks for listening, and it's now my job to introduce Ian Curthoys, who's, well, going to come up. He's an emeritus professor at the University of Sydney, such as myself, but he's done the most amazing vestibular. He's done a lot of the vestibular work, and some of the new tests that prevent you having to necessarily have water poured into your ear due to Ian's.
Okay, well, thanks, Bill, and I'm delighted to be here to talk to you about new ways to evaluate vestibular function and to tie some of the basic knowledge to what Bill has been talking about treatments. Because most of you don't know who I am, I'm a scientist. I've got 261 refereed papers on vestibular function, and I retired 11 years ago, and since then I've produced 98 papers and 13 this year. So I haven't exactly retired, and I'm enjoying myself immensely, and my research is supported by Garnet Pass and Rodney Williams, and I work with Daniel Brown and Payal Mukherjee. I want you to just have a look at this. What I'm going to do is just show you some of the... Come on. Oops. Come on.
We might have to switch back from the laser pointer.
Okay. Look at her eyes. She's getting unpredictable head turns, and her eyes are compensating for those head turns exactly, absolutely exactly. You can see there in slow motion. Perfectly. That is the vestibulo-ocular reflex. And in healthy people, it occurs thousands and thousands of times per day. And she is healthy and she does it beautifully. And of course the question is how and what goes wrong. Well, to understand how, we've got to come back down into the labyrinth of the inner ear. You can see these structures exactly where they are in the skull. They're deep down, and Bill knows this incredibly well. These semicircular canals, and that's about 6 millimetres across there. And this gives you an idea of these canals here which respond to that rotation. And most importantly, you can see this very thin tube here, right, going up into this big sac. That is the endolymphatic duct, and that is the endolymphatic sac, and down here is the cochlea. And that fluid goes right through the whole system, through the canals and all the way down to the cochlea, this endolymph, which is so important. And you say, well, this is humans. It's extremely difficult to work on humans, so we need to have an animal model. And most of the animal work is done on guinea pigs, and Daniel will be talking about this later on. And you can see how very similar the guinea pig labyrinth is. I haven't, in fact, reconstructed the endolymphatic duct and sac in the guinea pig, but they're very similar to what happens in humans. So, let me get my little pointer back. Right. So, within those bony tubes there are these fine membranous, within those bony canals there are these fine membranous tubes filled with this fluid, with these localised sensory regions in different places. The canals have got these receptors localised at the end of each canal for detecting angular rotations, and there are also receptors that I'll talk about later for detecting linear accelerations. What is new is that all parts of that system, every part now, can be tested in the clinic. These new tests developed in Australia, I'm proud to say. It's possible to test every part of that labyrinth to find out, because some people have got localised losses in some regions, the rest is fine. Even loss of one canal is really very disruptive to people's behaviour and experience. Now we can test them all. So how do they work, and and what happens when they go wrong? Well, the test that Michael Halmagyi and I found in 1984 is an incredibly simple test. It's what you saw already. It's called the head impulse test. Now we can use video to measure the eye movements and the head movements to demonstrate this corrective response. Video head impulse test. It's a very simple manoeuvre. Give people those kind of abrupt head turns, which, believe it or not, even people in the midst of vertigo attacks don't mind too much. They're miles better than that caloric test, and they're much, much faster. This test now is simply taking off around the world. I'm just back from China, where they've fallen upon it because they've got astronomical numbers of patients and they need fast tests. And this is a terrific, simple test. And this, the essence is, if we measured the eye movement and the head movement and superimposed them here, we'd get data like that, where the eye movement exactly compensates for the head movement. How does that happen? Well, to understand that, we've got to go all the way down to the canals itself. This is one human semicircular canal, these duct here, and that's about 1 millimetre there, with the receptors sitting on this structure. And during that head turn, as the head turns, the fluid within the canal deflects those receptors. It's as simple as that. It's as simple as that. And people diagram that like this. This is ridiculous. This is ridiculous because, in fact, this huge deflection there is nothing like what happens in real life. We're dealing with a super sensitive system. Deflections of micrometers, even of nanometers. Nanometers, in fact, activate these cells. It's amazing to me that more people don't have more problems, more vestibular problems. This is an amazingly sensitive sensory system. So, why then do we have these problems with vertigo attack? Well, the vestibular system is very different from every other sensory system, and that is so different because the two sides work together so closely. If you turn your head to the left, you are simultaneously causing that fluid flow in the left canal away from the receptors, and in the right canal towards the receptors. Okay? The brain has evolved to take advantage of that difference. Okay? Every head movement in healthy people involves this interaction between the two sides. So when you turn your head, you are activating one side. Turn your head to the left, you're activating the canals on the left side and simultaneously inhibiting the canals on the right side. And the brain says, I'll take the difference between the two. And that it uses to generate that beautiful sensitive response so accurately. That's during a head turn. Think about what happens for someone seated still, their head absolutely still, with no head movement at all, but that disease. Okay? If one side goes up, like Bill was talking about before, it's exactly equivalent to a real head turn. So you get all of these symptoms exactly as if your head was turning. You get the eye movements, you get the vertigo, and you get the falling, the postural changes. So a stationary patient with vestibular disease has got a very similar neural imbalance to that during a head turn, and all the symptoms simply follow. That's why you've got vertigo, because you've got that imbalance. So how does high drops affect, and Meniere's affect canal operation? Well, this is a very simple schematic diagram of the kind of thing that happens in high drops and Meniere's disease. Realise we've got those membranous ducts, very delicate membranes embedded in incredibly dense bone, but if the fluid control is not right, then those membranes swell. That's high drops, and it's shown here. It's a false idea because this is showing uniform swelling everywhere. High drops is not like that. Different regions, we know from scanning that different regions of the inner ear swell differentially. And that is one reason there's such variation between patients. This is an incredibly complex disease to deal with because not only does it change over time, but there are big, big differences between patients depending on factors which we're still trying to find out, and Daniel will talk about later on. But we, with my colleague, I work with a lot of people around the world, and I've got a very good friend in Italy, Leonardo Manzari, and we tested what happened to that head impulse response in Meniere's patients, and we found data like this. This is a different plot of that head versus eye velocity. This is a healthy subject here, and you can see head and eye velocity for the two sides superimposed. Here we've got a Meniere's patient. Everyone in this room can see the difference. There is this enhanced response with this very early onset. I think that's due to that high drops, and the fluid dynamic modelling is supporting that idea. That extra fluid is in fact causing those receptors to be bent more quickly and more extensively, resulting in that. And you say, well, that's not very convincing, show me something better than that. You've got one normal and one patient. Well, I'm a scientist, so I deal in data. There are 6 normals, and you can see they're all just about the same. There are 6 more normals, and you can see they're all just about the same. They're the patients. These are patients, Meniere's patients. And you can see how this systematic pattern varying between people, it's not exactly the same. They're the normals, they're the patients. They're the normals, they're the patients. Right? And here are patients with migraine-related vertigo. Right? Very similar patterns of response to what's found in Meniere's. So my hypothesis is that high drops changes that mechanical operation of the semicircular canal that I explained to you. Dealing with this super sensitive system, you only need little changes to cause havoc, and I think that's what's going on, and the modelling supports that. And we're in the process of quantifying that abrupt onset and pushing it, because I think this is going to give useful information to help diagnose people with high drops who are at risk of developing Meniere's disease, because that's one of the goals I've got of trying to prevent Meniere's disease in people in the future. But what about the other part of the inner ear, the otoliths? Well, I'm going to tell you things which are very new, and to many of you will be very strange, because there's been a huge amount of work on otolith function, and it's shown that most of the old ideas about the otoliths here just being sensitive to tilt, that's true, but they are just so incomplete. These sensors in the inner ear are doing much more than being sensitive just to tilt. They respond to sound. They respond to vibration. I've shown that in the guinea pig, and I will show you how here. These are the way people used to schematise the otoliths. Here, the utricle and the saccule is drawing flat plates of receptor cells, polarised, and with these beautiful images showing the otoconia like this. By the way, these otoconia don't really sit like that. Otoconia have got things like reinforcing rods going through the crystals. They're held in place very firmly in most people by essentially biochemical reinforcing rods, not by just floating around. Very interesting why they're displaced, but I'm not going to go there now. And of course, people have simplified things like this. They say that it's head tilt is what activates the otoliths, and of course that's true. But what's new? Well, what's new is when you look carefully, those receptors are not uniform at all. There are big variations across those receptor surfaces. They're very sensitive, like canal receptors. In fact, the sensors in the vestibular part of the inner ear, the individual receptor elements, are almost as sensitive as cochlear receptors. When you actually, people have actually got in and deflected them by these nanometer amounts and measured the response, and they just are remarkably sensitive. It's not the sluggish system that people have thought of for so many years. Nanometers are the threshold down there, and they're activated by sound and vibration. And that's turned out to be very useful for testing, for identifying what's going wrong with these otolithic structures. So let me show you this kind of variation. This is a view looking straight down on one of these receptor surfaces. This is from Japanese researchers in 1967. This guy actually drew by hand every single one of those receptors. Every dot on that is one receptor. Just extraordinary, and of course it's been confirmed by results since. But everyone in the room can see this dark band here. It's a specialised region where there are very fast receptor cells that look like this, called type 1 receptors, with a hair-like projections projecting up into that otoconial mass. And if you look straight down on it, you can see here, that band here called the striola, and you can see that the receptors there are in fact shorter. And this shows you exactly so. So the idea that you've got these simple receptors that are all the same height all the way across this uniform membrane is just totally crazy. Here, some receptors at that striola are 5 microns high. Other receptors are 30 microns high. It's a highly differentiated system all the way down in the periphery. And that shows you even more clearly. This is a chinchilla. You don't need to worry that it's a different species. The human is very similar to this. We know that. And that's that region that I described. Oops, there. And these other type 2 cells have got very different characteristic responses. But here are the short guys, and here are the tall guys. These huge cilia projecting up into the otoconial membrane. Well, I studied these by recording from single nerve cells in guinea pigs, anaesthetised guinea pigs, and presenting sounds and vibration and finding out whether these vestibular receptor nerve cells actually respond to sound and vibration. And many of them don't. Most of them don't. They just don't do anything to sound and vibration, which is very disheartening. But in fact, some of them respond incredibly strongly, like this guy. This is responses from one single neuron. Here, each spike is one action potential going down that cell. And this is vibration, and you can see the increase in firing to vibration and the increase in firing to sound. This is not a cochlear neuron. This is a vestibular neuron, and I know that because I traced it all the way back, injector tracer, and it comes from the utricular macula of the guinea pig, which looks like that. So now we've got a system, the vestibular system, which is giving the brain, actually part of it is giving the brain information about sound and vibration. And these are thresholds for a whole host of different neurons to different frequencies. These are vibration frequencies, 500 cycles per second, 1,000 cycles per second. And when you come right in and look at it carefully, in fact, when those neurons fire, here, exactly when they fire, is locked to the stimulus, just the same way as it is in the cochlea. That phase locking occurs for vestibular afferents as well as for cochlear afferents. The brain is getting complex information from these structures which people have simplified for so many years as just responding to tilt. This is their response, their threshold to sound, okay? And the two regions respond, have got very different thresholds. For me, it's extremely exciting to see what might be happening. And just very recently, we have used the fact that this macula, this structure sensitive to gravity, in fact is not attached to bone, it floats. It floats. And it's suspended like a hammock. There are fine fibres that take this sensory system and suspend it like a hammock. And I think this is the key to understanding how this system actually responds to sound and vibration. With Daniel and Chris, we've used laser techniques very recently to show that during sound and vibration, this whole vestibular sense organ moves up and down, locked to the stimulus. And different regions of it move differentially. This is fluid dynamic modelling, finite element analysis modelling from a colleague in the US showing different areas of this macula responding differently to different frequencies. This is an entirely new understanding of how the otoliths work. This physiological evidence underpins the use of sound and vibration to test the otoliths, because now this test that we helped develop delivering vibration here, which stimulates the two labyrinths and results in these little potentials being picked up by electrodes just on the skin here. These are due to otolithic afferents projecting very quickly, it's only 10 milliseconds from there to there, very quickly up and generating these very small potentials, which are extremely useful for identifying just the status of the utricular macula and the saccular macula on the two sides. And these ovemps and cvemps, rather like the V-hit, are altered in Meniere's disease. We published that many years ago that you can see here normal, healthy, or quiescent, Meniere's patients during quiescence as opposed to at attack. There's a very big increase in the size of that potential. Again, I put that down to changes in that fluid volume in the labyrinth during hydrops. During attack, we're still working on it. I just want to point out that that test that I showed you, that head impulse test, complements what Bill was saying earlier absolutely beautifully, because now people are using one-shot gentamicin therapy for Meniere's disease, and the way they track how well it is working is by using that head impulse test. My colleague in Paris uses single-shot gentamicin and delivers that head impulse to patients a week after they've had that shot. And she finds, and has reported, and I'll be reporting in a conference next year with her, that you don't need to ablate the entire function of the canal, as was the initial idea with gentamicin therapy. You just need to take the icing off the cake and the vertigo disappears. Okay, so people still have got quite a lot of residual canal function, but just reducing it a bit benefits many patients by alleviating that vertigo. And that head impulse test now is being used to identify just how far to treat these particular patients. One reason patients vary so much, by the way, is that some people have got not just one membrane in front of their round window, they've got two. They've got two. It's like double glazing on a window. So you pump that stuff in, and obviously it's not going to get into the inner ear, and which is going to explain why a lot of people have got, it doesn't work as effectively, and why you need a procedure like VHIT in order to assess it. So these new tests are allowing us to probe just what happens in the inner ear during high drops and Meniere's disease. Thank you very much for listening.
Okay, I'm going to start the second session by introducing Dr. Selene McNeil, who runs a healthy hearing and balance, yeah, healthy hearing. And she did her PhD in Meniere's disease, in particular seeing what happens to the hearing during the attacks of Meniere's disease, but her other great interest is also tinnitus, so she's going to talk about that as well.
Okay, so how does this go? Okay, thanks, Prof. Okay, can everybody hear me? All right, so I'm going to move down from the very important research that's going on in the background, and I'm going to talk to you about more practical things we can do to improve quality of life of people with Meniere's disease. So Meniere's disease, as you know, is a very sneaky condition. It slowly destroys the sense of hearing and balance. So we rely on 6 senses to stay connected with the world. The sense of smell, the sense of taste, touch, vision, balance, and hearing. So the sense of touch and smell and taste, they give us a lot of enjoyment, and luckily people with Meniere's disease do not have those sense affected. When you lose partially or totally one of our senses, any one of them, we can run into trouble. For example, if you lose your sense of smell, you may miss out the toast burning in the kitchen. When we lose our sense of vision, luckily there are things we can do about it. We can aid with glasses and things improve. I like to point out at this point that for Meniere's disease, the sense of vision is very important, because when you lose your sense of balance, you rely very much on the sense of hearing to keep your balance together. So balance is the sense that contacts us with space. When we have good sense of balance, we can walk straight with our eyes closed with no problems. When you have a good sense of balance, we don't bump into things while we're walking. We do not fall for no reason. We can dive in the ocean and know our way up with no problems. When you have a problem with your balance function, that's quite a dangerous thing to do. You should never do things that you lose your sense of vision with if your balance is poor. So when we have a good sense of balance, we don't have vertigo attacks. We don't have motion sickness. Unfortunately, Meniere's disease impairs our sense of balance, and I'm sure most of you who have the problem know very well how bad it is. Hearing, which is more what I'm here to talk about today, also is the sense that connects us with the surrounding world, and unfortunately, in Meniere's disease, hearing is impaired. So when we have good hearing, we are able to have a conversation with no problems in any situation. We can participate in parties with family, we don't miss the punchline, we hear everything that goes around. Our television is never too loud, we don't annoy our neighbors with loud television because we can hear very well without having to pump the volume up. When we have good hearing, we can go to the movies and we can hear everything, never mind the accent of the actors. We can still hear and understand what goes on. When we have good hearing, we can monitor our own voice. We don't need to talk too loud in situations that it's inappropriate. When we have good hearing, we can find our phone when it's ringing and we don't know where it is, because our hearing helps us to localize the sound. So when we have good hearing, we can hear from both sides. So if you're on a dinner table, if somebody talks to you on this side or on that side, we can hear from both sides. And also, when you have good hearing, we do not hear our tinnitus as much. Because funny enough, everybody has a little bit of tinnitus in the background. Everybody sitting in a very, very quiet room, if you listen very hard, you're going to hear some noise, internal noise, that is known to be some neuronal activity that is quite normal. But if your hearing is normal, you're not hearing those activities because you hear the environmental sounds that masks that tinnitus. So unfortunately, people with Meniere's disease do not have good hearing because Meniere's disease gradually destroys natural hearing, and it also causes tinnitus. So tinnitus is a perception of sound when there is no external sound entering the ears. And it comes in different sounds. It can be ringing, it can be a hissing, it can be a humming. In Meniere's disease, it's usually described as a roaring sound for most people, but it varies. And some people with Meniere's disease also describe that they can hear their heart beating together with their tinnitus. Quite common in patients with Meniere's disease. So the way I like to explain how tinnitus gets worse for a lot of people is when you have a hearing loss, you're always going to have to put some effort into hearing. Every time you put some effort into hearing, if you have tinnitus, you're going to perceive your tinnitus more. If you perceive tinnitus, usually you get stressed. When you put effort into hearing, you also get stressed. And that becomes a vicious circle. To break that, the best way to do is to address the cause, which is usually the hearing loss. So how can we improve hearing loss? We can rely on technology. We can have loudspeakers, like we have here today. I have a microphone, I have speakers all around, I'm talking, sounds are louder, you can hear things louder. You can ask people to talk louder, to shout, or you can wear the good old hearing aids that everybody dreads. So hearing aids are customized technology to improve individuals' hearing. Hearing aids and cochlear implants are the individualized technology that we have available for people with hearing loss these days. So Meniere's disease affects usually one ear. So when you have a hearing loss in one ear only, we call that a unilateral hearing loss. Hearing loss in one ear creates a lot of confusion in the brain. The brain needs information from both ears to be able to distinguish background noise from what you want to hear. You need sound coming from both ears to be able to localize sound in space. When you have only one hearing ear, you can't do those tasks. So when you have only one good ear, it's very hard to have a conversation in background noise. You cannot tell where sounds are coming from. You usually ignore the person coming from your bedside. And that gives a lot of neck problems, because a lot of people with unilateral hearing loss have sore necks because they're forever turning their heads to accommodate for the sound to come to the better hearing ear. So, but unfortunately, Meniere's disease sometimes suddenly attacks the other ear. And that's when we deal with a bilateral hearing loss. So bilateral hearing loss is when you have hearing loss in both ears. But in Meniere's disease, usually there's a difference. One ear is better than the other. So both are bad, but one better than the other. So when you have bilateral hearing loss, either by Meniere's disease or any other cause, the problem is that it becomes very difficult for you to hear in most situations. Communication becomes very difficult, and as a consequence, people become very isolated. So hearing loss, tinnitus, fullness, and vertigo are fluctuating symptoms in the early stages of Meniere's disease. And that's what makes things a little bit more complicated. So fluctuating hearing loss means that sometimes your hearing is bad, sometimes your hearing is good. Sometimes the fact that your hearing goes down may be an indication that you're about to have an attack of vertigo. Sometimes you cannot predict this attack. So it's quite a fluctuating. You've got things going up and down all the time in the system. So and tinnitus is another symptom of a hearing loss, as I explained before, and one of the symptoms of Meniere's disease. So in the initial stage, tinnitus may become louder just before you have an attack. So usually people say, well, I start feeling this fullness in my ear, this roaring noise starts to increase, and I get an attack of vertigo. So tinnitus in that sense may be a warning for you that you are about to have an attack of vertigo. But as the disease progresses, things become more stable. This fluctuation is not as dramatic, but hearing becomes just bad all the time, and tinnitus becomes louder and more annoying. So the worse your hearing, the worse your tinnitus is perceived. So another characteristic of hearing loss in Meniere's disease is what we call recruitment. So a lot of people with hearing loss, they say, well, I don't think I have a hearing loss because when sounds are loud, they really irritate me. It sounds a lot louder. And that for people may mean that they're hearing more than they have to or they should, which is not the case. So recruitment is a sign of some damage in the cochlea. Sounds that for people with normal hearing are perceived as moderately loud. People with a hearing loss perceive these sounds extremely loud and uncomfortable. So, and another characteristic of the hearing in Meniere's disease especially is what we call diploacusis, which is that perception of distortion, sound distorted. And a lot of people wear earplugs to try to minimize this problem. So it's very common to see people with unilateral Meniere's disease, with a hearing loss in one ear only, walk in the clinic with an earplug. And the rationale for that is to try to minimize the sounds that are distorted, to minimize the sounds that create discomfort. And in fact, you're doing yourself a disservice when you're doing that, because the more you protect your ear from sound, the more sensitive it will become, to a point that you can develop hyperacusis, which is an extreme sensitivity to sound. And you don't want that. So of course, to protect your ear is very, very important. But when the sound around you is harmfully loud, just ordinary everyday sound that's not going to damage your ear, you're not meant to protect your ears from them. So this is quite a cute, actually I put a photo there, that's my niece. As a good audiologist's niece, she's protecting her newborn baby from the sound of the blender. I thought that was really cute. And she did that without any warning or suggestion. So, okay, so the more you deprive your brain from sound, the more you will hear your tinnitus, and the more sensitive you'll be from sound. So what you really want to do is to expose your brain to sound. So auditory deprivation is the term we use to define lack of sound stimulation. So if you don't attend to your hearing loss for long periods of time, you end up losing memory to sounds. Your ability to understand speech also deteriorates. So the longer you live with a hearing loss, the harder it will be for your brain to adjust to sound. And recent research even suggests that dementia may be a consequence of untreated hearing loss. So management of hearing loss helps to improve our ability to hear. It masks tinnitus perception and reduces sensitivity to loud sound. And also helps to minimize the impact of dizziness. Because when you have one bad ear and also your balance is also impaired on that side, when you finally correct your hearing, it improves your overall sense of space. So even if your balance is poor, the fact that you can hear from both sides help to keep your balance a little bit more stable. It doesn't stop vertigo, that's not what I'm saying here, but improves your overall sense of balance. So attend to your hearing as soon as possible. When you notice that you have a hearing loss and that's affecting your life, go ahead and do something about it. early intervention will minimize the long-term effects. So, customized sound amplification using hearing aids is the easiest way to manage your hearing and to avoid sound deprivation. A word of caution here, hearing aids are not one size fits all, so they really need to be adjusted properly for your hearing. So they are digitally programmed, they equalize sounds at different frequencies depending on your hearing loss. So soft incoming sounds are amplified to become audible, and loud incoming sounds are compressed to comfortable and safe levels. So, but we have a problem with Meniere's disease because we know the hearing fluctuates. Some days hearing is good, some days hearing is not so good. So before we do anything, we need to understand the condition of each individual before we go ahead with any intervention. So I would advise you to choose wisely who you entrust with your care. I would also warn you that you can buy hearing aids anywhere these days, and you may get a very good deal, but it may not suit your needs, especially if you have Meniere's disease. So hearing aids are effective at improving hearing and reducing tinnitus, providing hearing fluctuation is properly addressed, especially in the first and second stages of Meniere's disease. So hearing fluctuation means that the hearing aid will be good one day, not so good next day. So how do we deal with that? So first let's have a look. The study I did many years ago, we looked at the different patterns of fluctuation that happens in patients with Meniere's disease. So in stage 1, the fluctuation happens in the low frequencies, and in the first stage, some periods, the hearing even goes back to normal. Second stage, the hearing never goes back to normal, but the fluctuation is more in the mid-frequencies. Third stage, the hearing never goes back to normal. It's more like a flatter type of hearing loss, but what we saw that there's still fluctuation even though the disease is supposed to be burnt out. So as I said before, first stage is low frequency. In the first stage, very rarely you will need a hearing aid because the hearing will go back to normal for periods of time. And the tinnitus at that point may be a friendly reminder that you're having an attack. So you may want to listen to your tinnitus, which is the opposite of what we say for most tinnitus cases. We usually advise people with tinnitus to try to ignore the tinnitus, don't listen to your tinnitus. But at the first stages of Meniere's disease, it may be worth a while listening to that tinnitus because that may be the warning that something is about to happen. So in the second stage, hearing fluctuates, and at that point, a hearing aid is quite important. But that's when you have to deal with the fluctuation. So once we know the fluctuation exists, we can provide the patient with technology that will allow them to address the fluctuation by programming their own hearing aid as the hearing changes. On the third stage, the hearing still fluctuates, but not as much, so just a volume control on a hearing aid is enough to adjust up and down for the changes as they occur. So mobile technology, hearing aid programming hardware and software are useful in the management of hearing loss and tinnitus. The process of fitting hearing aids for patients with Meniere's disease is different. We have to remember that the hearing test that you do in the clinic is just a snapshot of your hearing at one point in time because we know that the hearing changes. So the best way for you to know your changes is for you to do that yourself. We usually empower the patient to do the hearing tests at home using mobile technology so that you can check for yourself and bring back to the clinic so we can analyze with you what's happening with your changes. So self-monitoring of symptoms are quite useful because it helps the patient to understand their own condition, and that reduces a lot of stress because the unknown is usually quite stressful. So if you know exactly what's happening, even if it's unpredictable, at least you understand your condition a little bit better. So self-monitoring is recommended before we select the right hearing technology for you. So, but you need to remember that adjustment is a gradual process. It takes time, but it's worthwhile because the results of improving your hearing keeps the conversation going, keeps you socially engaged and participating and having a meaningful life. Unfortunately, sometimes the hearing loss becomes so severe that hearing aids are no longer useful. So when you get to that point, your audiologist should be able to advise you to consider a cochlear implant. So a cochlear implant, I'm going backwards. A cochlear implant is the last option when the hearing aids can no longer help. And cochlear implants improve hearing and also reduce tinnitus perception. So my takeaway message for today is that yes, hearing loss and tinnitus can be helped in Meniere's disease. There is a hearing solution for each stage of the disease. So I'm going to stop here and I will introduce Dr. Payal Mukherjee. She's a surgeon and she'll talk to you more about cochlear implants.
Thank you for having me here firstly. My name's Payal Mukherjee. I'm an associate professor of surgery and I am a surgeon. I get involved with Meniere's disease at the patient front. And it is particularly, I suppose we're a partner in crime with the patients in the sense that we see particularly the suffering that our patients encounter with Meniere's disease, and it is a challenge to try to treat it, and particularly want to thank the vision of people like Leo and Bruce for constantly encouraging us to do better with our research to try and find a cure. And I'm sure Prof and Selene will agree that we're particularly lucky in Sydney to have access to minds such as of Daniel Brown and Professor Kurthoys, and to be able to take our clinical problems and combine it with their scientific expertise to work as a team to come up with solutions as best as we can. And in saying that, I really want to particularly thank our patients as well, who then volunteer on research trials to allow us to study their data and come up with solutions as best as we can. So this particular talk is about one such study that we did, and hopefully it allows us to communicate some of those research findings that we have back to our patients. So, as Professor Kurthoys mentioned earlier, the balance system is the vestibular system, the inner ears, is particularly unique because it doesn't work in isolation, unlike the hearing system. So when you hear, that mechanism comes just from that ear, whereas your sense of balance is not just related to the two inner ears, it's also related to how well you see, and also the input that you get from your spinal cord, your muscles, which all gets integrated in the brain. So when it is therefore particularly challenging as clinicians when people present with balance symptoms, because we need to not just isolate which ear it is, but we also need to isolate firstly, is it the ear or is it coming from other stimulus? And particularly when patients experience a sense of vertigo, which is, you know, the world spinning around, that really helps us isolate that problem to the ear. Meniere's is an interesting problem because it affects the hearing as well as the balance, and that really helps us sort of, you know, hone our systems down. But also just the type of testing that you have had explained to you today, that also helps us sort of be a bit more scientific in terms of what we're treating. So we have come a long way. I particularly want to share this video that one of my MD students made, who's graduating this year, and he got one of the highest marks for his MD for this project, and his project was to develop an animation to describe what happens in Meniere's disease, because a picture tells 1,000 words. So I just want to play this video. As Professor Kurthoys described, the inner ear is encased in a bony capsule, and within that bony capsule is a little tiny intercalated ducts which holds the endolymph. Endolymph is typically produced in the hearing part of the inner ear, called the cochlea, and really leads to, we're not sure if it's overproduction or underabsorption at this stage, probably a bit of both, leads to this sense of high drops, which is build-up of pressure in the inner ear. And that's when we typically see patients have fluctuating hearing loss. When this fluid cannot be absorbed away through the natural channels, it will reflux into the balance system, and that's often when people experience vertigo. But equally, if that relieves some of the pressure from the cochlea, we see that the hearing does improve. So that's a very simplistic animation of what happens in Meniere's disease. The other thing, as you know, with Meniere's disease is that ideally what we want to achieve for our patients is optimal control of their vertigo and also optimize their hearing at the same time. But the problem is that if the disease itself is destructive to the hearing and the balance, and when the disease doesn't do that, some of our treatment strategies, particularly in advanced Meniere's disease, it employs the same strategy. It's destructive to the hearing and balance. I just want to share a couple of stories of a couple of my patients that helps build up the reason why the study was done. So this is a young 35-year-old gentleman who presented to me with debilitating vertigo. He's on maximal medical treatment, strict diet. He couldn't drive because of the frequency of his vertigo attacks. And you can see that the left ear in the blue is worse, is the Meniere's affected ear, that his right ear is normal. He's also particularly challenging because he used to be a surfer, so he has exostosis in his ear canals, makes the ear canal very narrow. So we had a discussion and we gave him some gentamicin to see if that would minimise his vertigo attacks a little bit. And I wasn't sure that the gentamicin would work because his ear canal is so narrow, it's just hard enough to get access to the eardrum. And as a consequence of the tests that Professor Kerthoys and Professor Halmagi and Hamish McDougall's developed, the video head impulse test, we are actually able to monitor the progress to see whether the gentamicin works or not. This diagram down on in the bottom corner is a diagram again that Professor Kerthoys and Hamish McDougall have developed an app, and it sort of looks at the planes of the different canals. And the graph up here sort of gives us each of those 6 balance canals, the semicircular canals, to see whether gentamicins worked. And literally, if we sort of look at more sort of the left-hand side of the screen, we can see that there are some red spikes, which is sort of telling us that this test is never abnormal. We never see these red spikes in Meniere's disease, but we do see the red spikes if a patient's been affected with gentamicin. So that's how we know that the gentamycin's been absorbed in the inner ear. And for this patient, it was great because he did actually get very significant relief of his vertigo, and he's on to a normal life, playing soccer. So it's really good, because otherwise the other option we were looking at is complete destruction of that ear. This is another patient of mine, a little bit older, but similar age group, unilateral left-sided Meniere's, and he again had very. That's the last patient. This is the second patient. This is another patient of mine who has, again, very severe Meniere's, and I've seen him for a few years now. He presented to me initially with very light fluctuation of his hearing loss and then progressed on to develop vertigo. And you can see that he's in advanced stages of his Meniere's where he has very poor hearing in his left ear. Down the bottom, there's a little box which shows the speech tests, and on the x-axis is the volume of sound, and on the y-axis is percentage of speech he's understanding. And you can see that with very loud stimulation, his speech understanding is, at 20-30%. So even with a hearing aid, he doesn't really understand much speech. So again, with him, we decided we were going to give gentamicin a go. And this patient has a grommet in his ear because I used to put steroids through that grommet. And I thought, absolutely, it's going to work because we have such easy access to the middle ear and that's going to get absorbed. But you can see from his head impulse test that there's not really as much absorption. So we know that hasn't worked, and really the strategy for him to try give it another go, maybe in theatre or we are building up to a story for cochlear implant, but if his vertigo is quite frequent and if it doesn't settle down by itself, we might have to consider perhaps completely destroying his balance organ. It depends on the severity of his attacks and the frequency. So just to put that in perspective then, what I'm talking about is a procedure called a labyrinthectomy. This is a similar slide that Professor Kurthoys had up there. We have the hearing part of the inner ear called the cochlea and the balance part of the inner ear. And what a labyrinthectomy is a surgery where you destroy just the balance part of the inner ear, but the hearing part is intact. However, because they're connected, when we do that operation, what happens is a patient will lose all of their hearing. And until recently, we didn't have the ability to give that back, or we had the technology to give that back, which is through a cochlear implant, but not all patients were candidates for it. So what has improved is candidacy criteria for cochlear implantation. So what would happen is if we had patients with bilateral hearing loss, that's when we would start discussing cochlear implantation. But most patients with Meniere's disease only have one ear affected, so there weren't a lot of Meniere's patients we would be having this discussion with, except when our candidacy criteria changed for single-sided hearing loss, where we started to appreciate that having hearing in both ears was not only beneficial for sound localization, it was also important for speech understanding and very beneficial in suppressing tinnitus as well. And the other thing we found is that having sort of electronic sound in one ear was not, it didn't stop people from still benefiting from, well, electronic sound in one ear and normal hearing in the other ear didn't stop people from benefiting from the technology, so that was a big step forward. So I suppose what is a cochlear implant? And just want to play a little video. This is something that I use for my patients, a 3D printed temple bone, a 3D printed ear, which is easier to describe to patients what the technology is. So a cochlear implant includes one device, but there's two parts. One that's internally placed during surgery, and then the other that works much like a hearing aid that talks through the skin to the internal device. And this is the bony part of the surgery, where we drill a little hole in the mastoid bone behind the ear and get access to the cochlea. This is the internal device that's the electrode that sits within the cochlea that we put in through the back. And then what happens is we close the skin, at least for me, and I'm sure with Prof as well. There's no stitches to be removed, and usually in my practice the patient will then on their way out from hospital, they'll go down to the audiology suite, and I prefer the patient to be switched on, which is a process where the external device is being put on the very next day to expedite their rehab. So they're getting some appreciation of sound, and over a course of the next 3 to 12 months that sound gets meaning and their speech understanding improves. This is just a quick video of the surgery just to demonstrate the view that we get. So that little grey area where the needle is going, that's the round window where the electrode goes through in the during surgery. This is just the mastoidectomy, and this is just a view of the electrode. One of the other things as technology and surgical techniques have improved is this concept of soft surgery. So we know that the hearing and the balance organ are all working together, and the principle in every cochlear implant surgery is that you the more delicate, the less trauma there is, the more likely you are to be able to preserve the internal function of both the hearing and the balance. So one of the things that we do is that the device companies are making more and more delicate electrodes, so less traumatic electrodes, and our surgical techniques also evolved that we insert the electrode very, very slowly to make sure that there's as little trauma as possible, to the inner ear, and that's what's sort of enabling us to sort of push the candidacy barriers, and the device technology and the surgical technology and the auditory technology all working together to get better hearing in patients. So this sort of led us to this study that we did a couple of years ago, which was supported by a grant that we got from the Garnet Pass and Rodney Williams Memorial Foundation. And what we wanted to study is, does it make a difference to the hearing or the balance for Meniere's patient when we put a cochlear implant with a labyrinthectomy or without a labyrinthectomy? And to get larger patients, what we did was did a multi-centre trial across Sydney with cooperation from numerous surgeons, numerous audiologists, numerous centres and scientists as well. And we had two arms. We had a clinical arm and an animal arm of the study. And the clinical arm really was testing, firstly, we had a control group that was patients with Meniere's who were implanted with a cochlear implant without any labyrinthectomy surgery, and we were also testing patients who had labyrinthectomy surgery, but then we decided to split them into two groups. We said we'll look at the patients who were having a labyrinthectomy at the same time as putting a cochlear implant in, so one surgery, and then we'll also look at patients who've had a labyrinthectomy many years ago and they were undergoing a cochlear implant, because we were a bit worried that having the labyrinth open for a few years may cause scarring within the cochlea, may cause degeneration of the cochlear nerve, and therefore the outcome may not be as good. So we had these biases, but we wanted to actually have a look. And meanwhile, Daniel was having a look at the guinea pigs to perform labyrinthectomy in the guinea pigs, see what happens to the cochlea. Anything that we couldn't explain in the patients in our findings, he could then test scientifically in the laboratory. And really we were looking at both the hearing and the balance results. We got a really good large sample of patients, a total 33. Most patients obviously were in the control group because they didn't require a labyrinthectomy. We had about 11 patients in the test group, with 8 patients having simultaneous cochlear implantation and labyrinthectomy, and 3 patients who'd had labyrinthectomy many years ago and they were still undergoing a cochlear implant. And that's just a characteristic of the fact that, that group of patients is small to begin with. Patients who undergo labyrinthectomy, again, are not sort of more Meniere's patients will have a cochlear implant without a labyrinthectomy. So that bias in that is unavoidable, because that's sort of the patients you do surgery on anyway. And what we found, so I had all of these hypotheses, and I was a bit surprised with the results, because I thought, the hearing results are going to be different in one group, but they weren't. They all actually did really well, and it's probably an attribute to the reason people have hearing loss in Meniere's disease in the first place, and that's because what a cochlear implant does is stimulates the cochlear nerve directly. It actually bypasses the cochlear mechanism, and the reason you have hearing loss in Meniere's disease is a hair cell loss, so it's a cochlear disease. So it's probably why we see patients with Meniere's disease do so well with a cochlear implant from a hearing point of view. But what was interesting in the study is to look at all the stories of the different patients and their balance disorders, whether they had Meniere's in one ear, Meniere's in the other ear. It really sort of made me appreciate that really the decision making in this was, the hearing part was easy. It's really the decision making in terms of sorting out their balance issues, which is actually a more quality of life problem for patients with Meniere's disease than their hearing. It's not in some cases. That was sort of the key of the study. When I started the study off, I thought it was really the hearing results that I was interested in, so I was a bit surprised. And this is sort of just a very broad graph to demonstrate some of the hearing results. On the y-axis is the preoperative scores, so the lower down you are on the y-axis, the worse the hearing was before the surgery in that ear. And on the x-axis is the post-operative speech scores. So the further along you are on the x-axis, the better you've done after surgery. And you'll see, majority of the patients are sort of in the bottom right-hand corner, which they had very poor preoperative hearing and got very good post-operative hearing. There's a few patients up the top, which means they had good preoperative hearing but had good post-operative hearing, and it makes you think, why did they have a cochlear implant in the first place? But they were special patients. They had really, really severe vertigo, and they were undergoing ablative surgery, which was going to kill their hearing, but the hearing was then restored with the cochlear implant, so they did well with. I suppose looking at that, we sort of wanted to have a look at then the labyrinthectomy patients and the balance outcomes and amongst all of them. And I think to put it in, I'll go into detail a little bit, but to put it in perspective, overall the best outcome was in patients who ended up having a labyrinthectomy or cochlear implant. But not to say that all patients should therefore have a labyrinthectomy if they shouldn't. You should have a labyrinthectomy if you need a labyrinthectomy, but the good thing was they didn't then have any further issues with vertigo. They were simpler to manage. They moved on with good hearing, and particularly if they only had Meniere's in one ear. But most of the patients are not candidates for labyrinthectomy, so this is where the discussion got more complex. The other surprising thing was that patients who ended up having a delayed cochlear implant after a labyrinthectomy, it didn't necessarily mean that they had a poor outcome. There were only 3 patients, so the sample size was low, but one patient didn't do very well, but the 2 others got really good hearing. So it is possible. So if patients had a labyrinthectomy for a long time, like a long time ago, provided they have an MRI that shows good cochlea, that the cochlea is not scarred up, they are candidates for a cochlear implant, and they should have a cochlear implant if they need it. And this is sort of one of Dan's studies to show what happens in the guinea pig after a labyrinthectomy. And this is as early as 6 weeks. And you can see that in the green arrows show a little bit of scarring starting to develop. And certainly we've had one of my colleagues, Dr. Biggs, who's done a study in looking at MRIs in patients who've had a labyrinthectomy. And he found that about 30% of those patients did undergo scarring of the cochlear implants, of the cochlea. So we know that at least 2/3 of the patients who've had a labyrinthectomy, even after a prolonged period of time, still can be considered candidates for a cochlear implant. In the patients, I suppose the discussion points in the balance that really was sort of the crux of the paper was that patients normal patients, so patients who didn't undergo a labyrinthectomy with Meniere's disease, with a cochlear implant, a small proportion of those patients had fluctuating impedances or resistance of their cochlear implant, which Selene will love to discuss with you down the track. And I think this probably relates to the nature of Meniere's disease with fluctuating high drops. And it may be that, that fluctuation continues on, but patients just don't experience it after a while because their hearing and their balance systems sort of ablated, and they don't really then have, a sense of fluctuation anymore, but internally maybe there is ongoing fluctuating high drops. We tried to really study this further, and Daniel certainly put all the guinea pigs to test, and we had help from Cochlear. They gave us particular research electrodes for guinea pigs, and we tried to induce high drops in the guinea pigs and put a cochlear implant in them. And we didn't find that the guinea pigs behaved the same as humans, but ultimately we couldn't ignore what we found. But we know that the patients do well, but ultimately it just means that they may need to visit their audiologist a little bit more frequently than a normal cochlear implant patients, because they might need their impedances mapped. And this is just a graph of that study that Daniel did, where he's put a tiny little glass pipette, which you can't see, I suppose, so well, but there's a blurred structure, which is a little glass pipette that's sitting in the endolymph organ of the guinea pig, where he's inducing high drops. And as he's doing that, he's measuring, all of these graphs are just measuring and there's a cochlear implant electrode sitting through the round window, and he's measuring the impedances of that study. And we didn't think there was that much of a difference. The other things were in patients with bilateral Meniere's disease, and they were a particularly challenging group to manage. Which ear do you implant? So normally, if you were doing any surgical intervention, any cochlear implant or any operative intervention in the ear, you always operate on the worst hearing ear first. But with Meniere's patient, I think we have to look at it, make an exception, because Meniere's patients have balance issues as well as hearing issues. And we certainly had patients whose, their worst hearing ear was their only or better balanced ear. And luckily in this case that we had, again, one of Selene's patients, the patient had poor hearing in both ears, but just the worst hearing ear was his better balanced ear. So he ended up having an implant in his better hearing ear, and he did really well from his cochlear implant, and his balance was pretty good. And he actually then wanted to have a cochlear implant in his other ear, but the surgeon is very wise to hold back, because the cochlear implant is not known to be destructive to the balance. In fact, very little happens. But in Meniere's patient, I think they have a friable vestibular system, and once you've put in a cochlear implant, we don't know whether it's the Meniere's that's activating, or is it the cochlear implant that's done something. And it's difficult to dilute specify those variables. And the thing that you don't want to do is for the patient to think that an intervention has caused their balance to be worse. So I think sometimes you have good hearing and good balance is better than having best hearing and poor balance, like to have implant in both ears if you have bilateral Meniere's disease. And that sort of brought us to the third point, to say, what do the patients, and we didn't do any quality of life studies because this is a retrospective study, and I think it would be worth doing that in the future to see what do patients with Meniere's disease value more, their balance or their hearing, and maybe we aim for the best of both worlds, not for the best hearing and not worry about the balance so much, or vice versa, just focus on the balance but ignore their hearing symptoms, because as you've heard, they both need to be treated with. So I think if the labyrinthectomy is being discussed, if a patient needs a labyrinthectomy, we should try to give the hearing back at the same time, so the patient doesn't need 2 surgeries. But if the patient has had a labyrinthectomy a long time ago, as long as they have a good preoperative MRI scan, they can still have a cochlear implant. And if patients don't need a labyrinthectomy, we get really good hearing results, but sometimes these patients may need to visit their audiologists a little bit more frequently, but it's only a minority of patients. And the other thing is also, I think it's really important, especially for Meniere's, that for our patients and also clinicians to appreciate that diligent recording, getting objective measurements of the hearing and the balance system is really important for us to understand what's going on. We are exploring other research tools in terms of looking at technology such as VR and 360 videos, and looking at the rehabilitative aspect of vestibular symptoms. So those of you who have the pleasure of meeting Elodie Chirovano in my clinic, that's part of all the research that we're doing. So look, thank you so much for all your participation, and I'm happy to answer any questions.
Okay, well, welcome back everybody to yet another Meniere's Research Fund Symposium. It's great to see all of you here, and I also welcome those of you who are tuning in online. And just on that note, I also wanted to thank very much to Mr. Steve Pascoe for setting up the online stream, and also to Bill Gibson for organising the streaming as well. To begin with, I just thought I'd give a little bit of an overview of the Meniere's Research Laboratory itself, because I know many of you don't probably know where it is or what it is. We're based at Sydney University in Camperdown. We're within the Brain and Mind Centre, which is a building about 2 streets west from Royal Prince Alfred Hospital, between Camperdown and Newtown, that kind of Camperdown Park area. We're on level 5 of the building, and within the level 5 floor, we occupy about a third of the floor space. Recently, within that level, shared resources, a shared microscopy centre is actually set up shop, which is actually really great for us, because our research is heading towards more novel imaging techniques, which are going to require some very sophisticated microscopes, which are now there and available for us to use. Within the laboratory, we have, at the moment, we've got a small team. We currently consists of 1 PhD student, Mr. Chris Pastras. We've got a research assistant, Liliana Sokolik, and we've got Ian Kouthois, who floats in and out of the lab between going on his invited overseas conferences. We've also recently been fortunate enough to be given a rather large bequest from Mr. Chris Woods. And with that funding, we're in the process of hiring an additional postdoctoral researcher who's got experience in molecular biology and immunohistochemistry, basically imaging and molecular techniques. We're going through the interview process at the moment, and we hope to have them recruited by about November, December of this year to head our research in that direction. We've also had a various array of other people come through the lab over the last few years. We've had about 9 students overall, but in the last 5 years come through the lab in various forms. And we've had other postdoctoral researchers like Dr. Yasuhiro Chihara come through and spend time in the laboratory as well. So in terms of the research that we do a huge variety of different projects, but what I want to focus on today is our main theme, which is to investigate endolymphatic hydrops. Now, many of you would be aware that, or might have been told that endolymphatic hydrops is the cause of your Meniere's disease symptoms, and that hydrops might actually result from a vast array of different underlying pathologies like autoimmune or immune disorders, viruses, allergies, genetic predispositions or genetic disorders and trauma, that sort of thing. And that any number of these pathologies will all result in a swelling of the membranous labyrinth within the inner ear, and it's the hydrops that then goes on and causes the symptoms of Meniere's. So we've first got to ask ourselves, well, how is the volume of the membranous labyrinth, how is this endolymphatic fluid normally regulated? And within that thinking, there's actually 2 main camps. So there's the idea that endolymph throughout the entire inner ear is regulated locally, that all of the cells that border the membranous labyrinth simply pump salt and water through them, and there's a local turnover of the fluid and salts in endolymph, and nothing really flows anywhere in a particular way. There's the other idea that basically endolymph, or the salts and water, are actually secreted within the cochlea, and there's this very slow movement of endolymph up the membranous labyrinth, up towards the endolymphatic duct and sac, where there's a bit of evidence to suggest that's where the key area that endolymph is reabsorbed. There's also research suggesting that that actually doesn't normally occur and only occurs when there's a bit of disturbance within the inner ear. And the thinking there is that the endolymphatic system has this inbuilt mechanism where if there is a disturbance within the endolymphatic fluid, there's a bit of cellular debris or a bit of antigen, some bacteria or viruses, that they're shuffled off towards the endolymphatic sac and duct to be processed. There's several things that can go wrong with those processes then. So in terms of abnormal changes in the movement of salts and water between the membranes, you can have an abnormal expression of various things like aquaporins, which is the mechanism that allows water to flow between different cellular compartments. You can have changes in the various protein pumps that pump salts into various compartments. And that can result in endolymphatic hydrops. And you can also have leakiness of the blood vessels as well, and that's certainly going to cause an influx of fluid into the inner ear and possibly into the membranous labyrinth and a swelling of the membranous labyrinth and causing endolymphatic hydrops. If you've got a blockage, though, of the path that allows endolymph to flow up towards the endolymphatic duct and endolymphatic sac, you could obviously, that would then lead to an abnormal absorption of endolymph, and that's one of the main theories of what causes endolymphatic hydrops. There's a blockage of the endolymphatic duct or a damage to the endolymphatic sac, leading to or resulting in an abnormal absorption of endolymph, and as a consequence of that, you develop endolymphatic hydrops over time. So in order to study particularly how the inner ear regulates endolymph fluid, we do invasive experiments in guinea pigs where they're anaesthetised, and we can inject various levels of artificial fluid into the various compartments, particularly the membranous labyrinth itself, within an anaesthetised guinea pig. And we can then monitor the function of the cochlea or the function of the vestibular system whilst performing these injections to see exactly what's going on whilst we're slowly increasing the volume of endolymph artificially, and then we can do post-mortem imaging to see where that fluid has gone. And in the past, we've done these experiments. We have several publications to do with exactly what happens when you inject artificial endolymph. Here's where we've injected artificial endolymph with a bit of dye into the cochlea, and you see that the dye stays within the scala media compartment. What we know as well is that when you are slowly injecting this artificial endolymph and when you're slowly increasing the volume of hydrops, you see a slow decrease in the sensitivity of the animal to low frequency sounds, just like what you see in Meniere sufferers. And spontaneously, in one animal, you might see a sudden recovery of function. And other people had seen similar phenomena and suggested that there was a rupture of the membranous labyrinth. We did post-mortem imaging, and we also did a series of experiments where we performed several injections into one animal, and our results basically suggested that there wasn't a rupture of the membranous labyrinth and that something else was going on to cause those episodes of functional hearing recovery and functional loss of vestibular function as well. So that bit of research was again involving artificial end-length injections in guinea pigs, and it really went to try to provide an understanding of what causes vertigo attacks in Meniere sufferers. But that's not particularly what I want to talk about today. What I'm interested in is understanding exactly where end lymph goes when its volume increases. In order to understand where end lymph goes then, we had to have a system of being able to visualise where end lymph is diffused through the inner ear. And to do this, we developed a light sheet fluorescence microscope, which is simply a microscope that allows us to peer through the entire cochlear and vestibular system of a guinea pig. And what we do is we basically take the inner ear out of the animal after it's been killed, and we then treat it with some various chemicals. We put it on this microscope, and that allows us to scan through any particular part of the inner ear with almost cellular resolution, and we can basically see where the inner ear fluids go by if we add a little bit of fluorescent dye to the fluid that we've injected. So this is some results from a study we published last year, where we've injected artificial end lymph with this fluorescent agent into the interscalar media of the cochlea in these guinea pigs. And what we found was that the end lymph fluid diffuses throughout the scalar media, or the end lymphatic compartment within the cochlea. But what was surprising was just how much of that end lymph fluid was actually absorbed up the end lymphatic duct and into the end lymphatic sac. And this movement of end lymph fluid only occurred following those sudden recovery episodes. So it was a dynamic change, if you like, in where end lymph was diffusing to within the inner ear, suggesting that the end lymphatic sac almost was triggering some sort of absorption of end lymph. Moreover, when we had a more closer look at the end lymphatic duct and end lymphatic sac, what we found was a lot of this fluorescent end lymph was actually being absorbed up into the microvessel, the microcanals that surround the end lymphatic duct. And the end lymph was essentially being drained away from the end lymphatic duct within 20 minutes into the various blood vessels that are known to exist within the temporal bone that surround the end lymphatic duct. That actually lined up pretty well with what other researchers had suggested. One of the key issues that we had from this finding, though, was that the fluorescent agent that we're actually injecting is of a particular size that it's not like that dye is able to cross over membranes. That dye is so large it can't really get through cells, it has to go around cells. And that led us to almost think it seems as though there's actually a direct communication of end lymph within the membranous labyrinth and the blood vessels that surround the end lymphatic duct, like the two things are actually directly connected. And that's a bold statement because, generally speaking, everybody thinks of the end lymphatic compartment, the membranous labyrinth, as being a closed system, and end lymph is nothing like blood, so why would the two systems be in communication? But we actually went back and had a look at a whole bunch of different studies that had used various techniques, some very high-powered transmission electron microscopy. They'd used various techniques like in vitro fluorescence microscopy to examine exactly what was going on with the communication between end lymph in the end lymphatic duct and the vascular system, the blood in the vascular system surrounding the duct. And indeed, they had also suggested that there seems to be this direct communication of the end lymphatic duct with the microcanals that surround the duct. And indeed, that is primarily where endolymph is being regulated or absorbed. Now, why is that important? Because it gives us an understanding of potential mechanisms that could result in an abnormal absorption of end lymph and result in end lymphatic hydrops. So one of the main theories of what could be causing hydrops in Meniere sufferers is this blockage of the end lymphatic duct, or rather a blockage of the microvessels, the blood vessels that surround the duct. If you block that vascular uptake, you then no longer have your normal absorption of end lymph, and you'll end up with end lymphatic hydrops. Indeed, if you then look at the histological sections from post-mortem sections of Meniere sufferers, particularly Meniere sufferers at the early stages of the disease, what you find is the end lymphatic sac and the end lymphatic duct is actually quite normal. It's not like the duct and sac are completely clogged up with lots of immune cells and fibrosis. The lumen is actually quite empty. The blood vessels that surround the endlymphatic duct are also quite empty, but they're swollen. And this is exactly what we've seen in some of our research, which we'll touch on in a little while as well. One of the key features you do see, though, is that the membrane of the endlymphatic duct, so the endlymphatic duct, if you like here, is surrounded by this collagenous substance within the vestibular aqueduct, which is the bony portion of the inner ear. It's probably shown better here. You've got a bony duct, and within that bony duct, you've got a membranous duct. And the two things we previously had thought do not communicate with each other, we now believe that in normal ears, there is actually a little bit of outflow of end lymph via that membrane in normal inner ears, and that the end lymph is then drawn up into the microcanals that then pass that fluid off into the bony sinusoids of the temporal bone. But in Meniere sufferers, that membrane seems to be thickened, so there seems to be an abnormal level of, or there seems to be something wrong with the movement of fluid out of the end lymphatic duct. So we thought about doing experiments in guinea pigs to try and induce those kinds of changes. Now, one of the more classical ways of inducing end lymphatic hydrops in guinea pigs, there's a couple of ways. You can destroy the sac. That's the classic model of producing end lymphatic hydrops in guinea pigs. But it's not a very good model because Meniere sufferers don't have destroyed sacs. Their sacs are intact. So it's not a very good animal model. The other way of producing hydrops in guinea pigs is to put a bit of antigen, something that is going to interact with the immune system and agitate the immune system. And when you put a bit of antigen into the middle ear or onto the round window or into the perilymphatic compartment of guinea pigs, what you find is that within the space of about 1 to 2 weeks, the volume of endolymph expands. You have a moderate to severe endolymphatic hydrops within the cochlea. The endolymphatic sac and duct, interestingly, actually gets clogged up with this secretory substance, this glycoprotein, which gets secreted into the duct and sac. But then after about 2 or 3 weeks, that volume of endolymph starts to subside, and after about 4 weeks, the volume of endolymph has actually returned to normal. So it's really only a transient model of endolymphatic hydrops. And again, it's not a very good model of hydrops because there's not a chronic, of Meniere's disease, because it's not a chronic animal model of endolymphatic hydrops. But we thought about how this was being done in previous experiments, and in all of these experiments, the antigen was actually being placed into the perilymphatic compartment. So we thought about doing this novel experiment of putting the antigen directly into the endolymphatic compartment, which is where the main theory of endolymphatic clearance was actually that it was cellular debris or any antigen within the endolymphatic compartment would then be moved up into the endolymphatic sac and duct, and that if there was some abnormal ossification or scarring within the endolymphatic duct, that might be what causes chronic hydrops. So we basically, over the last year, we've performed a series of experiments. We've been injecting artificial end lymph with a little bit of antigen into scala media of guinea pigs and then stitching them up, recovering them for various periods of time between 1 day to 6 weeks, and then down the track having a look at exactly what's going on with both their function and their end lymph volumes. Now, the first series of experiments we did here, we've got the benefit of actually looking at both ears at the same time. So here's a normal endolymphatic duct and sac. It's very thin. There's the sac. There's a tiny little groove here. In this ear that we'd injected this antigen, I'm not sure if that's going to come up again, the endolymphatic duct and endolymphatic sac were actually, again, clogged up with this glycoprotein secretion within the duct. That's not new. We know that happens when you have a little bit of immune activity within the inner ear. But we then started with, okay, that's within a day. What we really wanted to do was to develop an animal model that had hydrops for several weeks after this intervention. And that had not been achieved before. So we started out, though, the first thing you've got to do is to make sure that the experiment that you're doing is not itself causing chronic hydrops. So the first thing we do is to just inject artificial end lymph with no antigen into scala media of guinea pigs. Now, from this point of the talk onwards, I'm going to show a series of blue images, mostly blue images, that show up very well on the computer screen. They may not show up very well on the projector, and I apologise for that. And for those of you online, you probably also won't get a very good view. So bear with me, and if you can't see the lines and the membranes I'm talking about, just believe me, they are there, and I'm very happy to show you some of the slides later on. So here's the control ear. This is where we've injected artificial end lymph into scala media compartment of a guinea pig, and we've recovered that animal for 4 weeks. And lo and behold, absolutely everything is fine. This is a very normal looking cochlea of an animal, and I was quite surprised at exactly how well this turned out when we first started doing it. And we can quantify, and there's no endolymphatic hydrops. This is this little tiny membranes here, which I'm not sure how well they show up. That's Reiser's membrane, and that membrane in Meniere sufferers and with endolymphatic hydrops is usually bloated and stretched outwards. These animals don't have that. We can quantify the ratio of the volume of the membranous labyrinth, scala media, to the volume of scala vestibuli as an indicator of the level of endolymphatic hydrops in the cochlea. Here's yet more examples. Here's where we looked in the same animal. We look at the endolymphatic duct and sac. Again, everything looks pretty normal. You've got a very thinnish looking, this is from a single slice, very thinnish looking endolymphatic duct. But if you actually look through a cross section, you've got the bony channel, and within that bony channel, the vestibular aqueduct, you have a little bit of cholineginous connective tissue, then connecting to the endolymphatic duct, which is takes up about 10% of the volume of the vestibular aqueduct. Yet more examples of control injections of artificial endolymph, just to show that we've done this several times. It's not always hunky-dory. You do, in some ears, have a bit of fibrosis and scarring throughout the inner ears. I should also point out that we're also measuring the function in these animals, and surprisingly they have very good hearing after 4 weeks of having these injections. There's a little bit of hearing loss in the animals that have a bit of fibrosis, suggesting that something wasn't quite right. But again, no evidence of endolymphatic hydrops, and their endolymphatic ducts and sac look perfectly normal to me. So we then moved on to putting a little bit of antigen into scala media. Now we started out with a 0.1% lipopolysaccharide. Lipopolysaccharide is the antigen, it comes from bacteria. It's what typically is one of the substances that's typically used to induce an immune reaction. We started out with this particular concentration because that's the concentration that other researchers had used when they put it into the perilymphatic compartment. The difference was we thought this is going to produce a pretty severe immune reaction, so we dumped the volume down by 10 times. So we're actually putting 10 times less antigen into the inner ear than researchers had classically done, but we're putting into scala media. So we did this. Whoa. Not what we were hoping to expect. So this is a month after 0.1% lipopolysaccharide into scala media, massive cellular infiltration, massive fibrosis, severe hydrops, which is good, but these animals were completely deaf and they had a bit of head turning as well, suggesting their balance function wasn't great. Not what we were hoping to see. What was interesting though is that you looked at these guys' endolymphatic ducts and sac, and rather than being clogged up or damaged and degenerated, the ducts were actually quite swollen and the sacs were quite swollen and typically empty of anything. So again, this is 1 month after this 0.1% lipopolysaccharide injection. And it was quite interesting that the ducts actually swell. The endolymphatic duct now swells out as far as it can. It almost takes up the entire space of the vestibular aqueduct, so it's swollen to its maximum volume. And we also we started out with the idea that we might be able to put in some fluorescent lipopolysaccharide and see where that antigen was actually being transported, whether or not the antigen was actually flowed up towards the endolymphatic sac and duct to be processed. Unfortunately, that technique didn't quite work because the fluorescent lipopolysaccharide is actually a little bit too small of a molecule, got washed out and cleared during the processing. So instead we turned towards using 1 micron beads that were conjugated with a little bit of lipopolysaccharide to see if indeed those beads were actually being transported up and towards the sac. There was a little bit of evidence to suggest, this is where we've done the injection, a little bit of evidence to suggest the beads primarily moved up towards the endolymphatic sac. We couldn't find any of these beads up in the duct and sac, however. And what you notice within a day of putting these things in, that the duct and sac is completely blocked, again, with this glycoprotein, and there's lots of homogeneous substance within the sacule as well. Nothing new, we've seen that several times. It's basically a strong immune reaction within the inner ear. So then we think, okay, great, we've annihilated the thing, too strong of a concentration. So we halve the concentration and we halve the volume. So now we're putting a quarter amount of the antigen in with a 0.05% lipopolysaccharide, 0.5 of a microliter injection into scala media. 4 weeks later, we're still seeing pretty severe cellular infiltration. Not quite at the level that we had before. Again, we've got really severe hydrops. I'm not sure if it shows through all that well, but the Reiser's membrane is basically distended, almost entirely taking up the space of scala vestibuli. But again, these guys are pretty much deaf after a month. And again, their endolymphatic ducts and endolymphatic sacs are swollen and empty most of the time. So it's showing that endolymphatic hydrops doesn't necessarily only result from a blockage of the endolymphatic duct and sac. Now, I'm not saying that I know that though the duct and sac here have perfectly normal absorption. It may not, but that we're not seeing the hydrops purely because of a blockage of the endolymphatic duct here. Here's yet more examples, again, really swollen endolymphatic ducts. One of the important points to point out as well is that the vasculature system that surrounds the endolymphatic duct also seems to be quite clear and indeed swollen as well. So it's not like there's a blockage of the microvessels that we think are actually primarily responsible for draining the endolymph away from the inner ear. Yet more examples. Here, though, we're looking at basically 1 week rather than a month. And within a week, you still see some remnants of this glycoprotein. The ducts aren't quite as swollen in these guys. There's less immune cell infiltration or cellular infiltration. But again, the hydrops is still really severe, even within a week of these guys. So we thought, bugger it. We'll drop it down by another factor of 5. We'll drop the volume down again. We're getting now to the level of antigen we can't really control. It's sort of trace elements of antigen. But we thought we're going to have to do this because we're getting to the point of injecting almost nothing to see if we can see no immune response. And fortunately, I'm not sure how well these show up. Here we see pretty severe, moderate to severe endolymphatic hydrops in most of our guinea pigs, often particularly in the apex of the cochlea, which is really good. Almost no cellular infiltration. This is 1 month after that initial antigen injection, which is great. This is what we set out to do. We wanted to see hydrops 1 month after putting antigen within the sac, or within the scala medium. We look at the ducts and sac of these guys, and in most animals it's pretty normal. If anything, there's a little bit of glycoprotein in it, but it's not swollen. So we don't quite know what's going on there. There seems to be this changeover point in terms of immune activity where you can have severe endolymphatic hydrops without a huge amount of cellular infiltration, and the endolymphatic duct and sac isn't blocked but does have some evidence of glycoprotein secretion. That's not always the case. In some animals, within a week, you do see swelling of the endolymphatic duct and sac, and you do see quite a lot of glycoprotein within those ducts. And sometimes you see almost very little hydrops, whereas in other times you see lots of hydrops with a little bit of cellular infiltration within the perilymphatic compartment. So we think we're almost there. We just need to titrate that immune activity a little bit more in these guys. And for comparison, we also put the 0.1% lipid polysaccharide into scala tympani for comparison with other studies. And we looked at these guys a month later. Again, lots of cellular infiltration within the inner ear, no real endolymphatic hydrops. The endolymphatic ducts and sacs look pretty normal, but that's, again, we expected to see this because we're looking several weeks after putting that antigen into the perilymphatic compartments. We then, as all good scientists, have to quantify our results so that we can report them neatly in a paper, because it's one thing to show a whole bunch of pretty pictures, but you can't do that in a journal article, so you've got to actually provide numbers. And in order to do that, we have to painstakingly go through and measure the ratio of scala vestibular to scala media, or if you like, we've also been looking at the volume of the endolymphatic duct in relation to this vestibular aqueduct. And we can look across the different concentrations, and we see that at about 0.01% we have clear endolymphatic hydrops with moderate to almost no swelling of the endolymphatic duct. The problem, however, is still that in comparison to our artificial endolymph injections, all of these models have pretty severe hearing, and even the guys with the 0.01% injections still have, after 1 month, almost a 60 dB hearing loss, and that's not what we wanted to see. So we want some animals that have a little bit of hearing loss but aren't completely deaf after a month, because if they're deaf, again, it's not a great model for Meniere's disease. And so we think that the next step is to basically drop that down, the concentration down a little bit further, to see if we can then look at these guys over a longer period of time. And if we've got that as an animal model, we can start to work on treatments in the laboratory. One of the other things we have to do is to actually assess what's going on with the endolymph absorption. And in order to do that, we have to study the permeability changes within the membranous labyrinth itself. To do that, we actually, again, we put in a bit of fluorescent dye into the endolymph that we've injected. And here's some animals where we've done, these guys haven't had antigen, but we inject artificial end lymph within the end lymphatic compartment. We see the end lymph being absorbed into the microcanals within the end lymphatic, that surround the end lymphatic duct. We also find often that you see a lot of that end lymph fluid appearing in the tuberculated bone, or if you like, the bony sinusoids of the temporal bone. And it's clear often that you see these very large communication ducts between the bone marrow sinusoids and the end lymphatic duct as well. That sort of gives us a better insight into exactly where end lymph is being absorbed in those ears. We've started to look at the changes in the permeability in those animals, but we've only done a couple of those experiments, and in both of the experiments we've done it in, neither animal had that much high drops to begin with. So that's something we're working on at the moment. So just to summarise that research so far, strong immune responses within the inner ear give you lots of cellular infiltration and fibrosis, really severe high drops. But interestingly, the ducts and sac are swollen and empty. Weak immune responses is almost what we really want to see, which is severe high drops in the apex, normal-ish ducts and sacs, but still their hearing loss is still too severe for us to be happy with that as an animal model of Meniere's disease. So we're still got to work on it a bit. Next, for that particular project is, again, as I said, lower the concentration of antigen to see if we can ping high drops without the hearing loss. And we need to keep working on quantifying those permeability changes to see exactly why high drops is developing in those animals. The next thing we want to work on is manipulating end lymphatic high drops. And one of the key areas we've thought about doing recently, or the experiments we've thought about doing recently, is to manipulate the paracellular permeability, or the permeability of the membranous labyrinth, to actually improve the outflow of end lymph as a treatment for end lymphatic high drops and Meniere's disease. We started out, I had an honours student start with me halfway through last year, and we thought we'd seen this, a few other researchers use this chemical called sodium caprate, often people call it C10. It's used in most pharmaceuticals that are taken orally to temporarily increase the permeability of the gut lining. And it opens up the gut lining, the epithelium, for about an hour, and then things resolve. So we thought, and others have actually used this as a technique for temporarily increasing the permeability of the membranous labyrinth. In order to see if it worked, again, we turned to perfusing through fluorescent end lymph within the end lymphatic compartments in a control situation. We can then apply just normal saline to the round window to see what it does to changes in permeability, and we see nothing. So most of the, if not all of the end lymph that we've injected is contained within the end lymphatic compartment. If you add a little bit of C10, sodium caprate, onto the round window when you've done this, you do start to see a little bit of the end lymph, the fluorescent end lymph, starting to leak out into the neighbouring compartments. Not a lot, but just a little bit. It didn't work that well. It was particularly prevalent in the base of the cochlea, not so much in the apex. If you add the C10 to the end lymph that you're injecting, what you find is that pretty much Reiser's membrane becomes completely leaky. All of the end lymph leaks out and is completely housed within the perilymphatic compartment. So we know it works. One of the other problems with this particular chemical is if you get it onto the bone of the cochlea as well, you're not only increasing the permeability of Reiser's membrane or the inner ear, you're also going to increase the permeability of the blood vessels that surround the inner ear, and you probably don't want that. So here's an experiment where we've injected fluorescent agents throughout the bloodstream of a guinea pig, and we've then applied 50 millimolar of this substance just to the outside of the cochlear bone, and we found that basically all the bone becomes immediately leaky. And surprisingly, the animal's hearing didn't change too much during this, but we probably wouldn't want to have those sorts of changes occurring in a Meniere's sufferer. I got the student to basically quantify the changes in fluorescence, which involved basically looking at intensity changes of that fluorescence along the different compartments. And again, the results showed up what we'd suggested, that with a little bit of this chemical on the round window of the guinea pigs, which is essentially equivalent to what you would receive with an intratympanic injection in Prof's office, you see a little bit of an increase in the membranous labyrinth permeability. No real functional changes. You get a bit of a high frequency loss for about 20 minutes, but after that, function seems to resolve. And that's what we'd hoped and we were expecting to see. And the reason why you'd get a bit of hearing loss is that if you're increasing the permeability of Reiser's membrane, you've also got ions and various things that are within end lymph that are also leaking out, and that's going to cause you a bit of hearing loss itself. but you're just hoping that that doesn't cause a permanent hearing loss, and that after an hour when things resolve, then your hearing comes back. And that also seems to be what's happening. We don't really think at the moment that C10 is going to be the best chemical to use. And indeed, we've actually started to realise that most intratympanic drugs, like gentamicin or dexamethasone, actually already have substances added to them to improve the permeability of the round window membrane. In particular, hyaluronic acid and I've gone blank the other one, but there's benzyl alcohol. They're preservative substances that added to lots of different drugs, in particular drugs that are injectables. And there's been several studies that particularly benzyl alcohol is really good at increasing the permeability of membranes. So we think that even just control injections of intratympanic injections may also be of benefit to Meniere sufferers. And that may explain some of the results that people have seen with sham surgeries. The next thing we wanted to look at was this idea that there's other ways of increasing the permeability or triggering changes with the permeability within the membranous labyrinth. One such technique has been to use glycerol. So some of you Meniere sufferers may have had this in the past where you were given glycerol tablets. So actually, has anyone had glycerol here before? Or urea? Probably lots of you have had urea. Glycerol is a lot more powerful, and basically what you find if you're a Meniere sufferer, particularly in the early stages, if you're given glycerol orally, within a space of about an hour or two, often your hearing improves, and you might be great, my hearing's coming back, there's been studies on this, and that lasts for about 2 hours, but then your hearing deteriorates again and often can leave a little bit worse. So they use it as a technique to help diagnose endolymphatic hydrops in Meniere sufferers. If you get a bit of hearing improvement after glycerol, it suggests that you've got endolymphatic hydrops. There's been a lot of studies done with glycerol in guinea pigs, where we've basically demonstrated, or back in the 80s, where they demonstrated that when you give guinea pigs lots of glycerol, several things happen. The endolymphatic volume does decrease, and it was thought that that happens because glycerol gets into the perilymphatic compartment and that draws the water out of the endolymphatic compartment. But there's been other studies that have demonstrated that what really happens is that glycerol triggers the endolymphatic sac to secrete this glycoprotein within the duct, and it's thought that this glycoprotein draws endolymph up from the cochlea into the endolymphatic duct and sac. And then within the next few hours after glycerol, that glycoprotein gets gobbled up and eaten away by various enzymes and macrophages, and the endolymphatic sac is swollen, but then slowly recovers after time. So we thought we'd try and exploit this idea that potentially glycerol can induce endolymph movement from the cochlea up into the endolymphatic sac. And we wanted to do this because we thought, well, there's one of the main problems with treatments of Meniere's disease sufferers, particularly with things like dexamethasone, as Prof talked about this morning, is the pharmacokinetics. You can put a drug on the round window or through the eardrum, but that doesn't mean it's necessarily going to diffuse very well throughout the inner ear. And it's particularly not going to get up to the endolymphatic sac, which goes through this very thin bony duct and into the brain cavity. What we think is that we might be able to use or leverage the effect of glycerol in terms of having it draw fluid up into the endolymphatic duct as a means for getting more drug concentration up into the sac, which is really where we need those drugs to be. So we've only done this in 2 animals or 2 or 3 animals so far, and literally I got these results late last week, where I've done an experiment where I've injected fluorescent endolymph into scala media in an animal which an hour prior to that I had given the animal lots of glycerol, and what we found was remarkably exactly what I expected, that endolymph was really drawn. I mean, pretty much all of the fluorescent endolymph was drawn up into the endolymphatic duct and sac, which is either filled with the endolymph, which I don't think so, but I think there's a lot of glycoprotein and that cellular infiltrate in the duct and sac within that hour after glycerol. So I think this is a promising technique which we might be able to couple with therapies for Meniere's disease. Does it actually get the treatments, the intratympanic drugs, directed towards the endolymphatic sac in Meniere's sufferers? Just finally, one of the projects I'm also starting to work on with a couple of guys from the School of Biomedical Engineering is this idea of using focused ultrasound. Now, Focused ultrasound is, I mean, lots of people have had ultrasound for various reasons. We've now come to the realisation you can actually use ultrasound transducers, the sorts of things that pregnant women have rubbed over their bellies. You can design them such they focus the ultrasound energy to a particular very small spot. And brain researchers are going wild about focused ultrasound at the moment because what they've realised is they can use focused ultrasound to increase the permeability of the vasculature system within very small selected regions within the brain. And if they do that, they can then give patients who might have brain tumours or various disorders injected agents, and they can then, which typically don't diffuse into the brain. One of the main problems with getting drugs into the brain is that drugs don't readily cross the blood-brain barrier. So it's very difficult to get drugs into the brain, and even more difficult to get drugs into a specific region of the brain. Using focused ultrasound, they've managed to increase the permeability of a small region, and they can basically then have drugs diffuse through the bloodstream and just leak out in the region that they want. And that it happens because it increases the paracellular permeability of the vasculature system. We looked at this and we thought, hang on a second, and these guys were looking for a project to do anyway. And I'd been interested in myself as an idea of modulating the paracellular permeability. And we thought maybe we can use focused ultrasound in Meniere sufferers to temporarily increase the permeability of the membranous labyrinth and improve the outflow of end lymph. Well, as it turns out, ultrasound was actually used extensively for Meniere's disease sufferers throughout the 70s, 80s and early 90s. And I wasn't aware of any of that. Of course, Prof. Gibson's been there and done that, and he was absolutely aware that ultrasound was used back in the day. And particularly it was used within Sydney. So it was developed, the idea of using focused ultrasound to treat Meniere's disease was actually pioneered by the Ultrasonics Institute of New South Wales in Sydney. The idea was that basically you could get this kind of tiny little ultrasound transducer and apply it to the bone and irradiate the inner ear with ultrasound. And what they found was, or the early studies found, was that even with patients on the table, they found relief from their subtle vertigo symptoms whilst on the table. So there was certainly something going on there. As the treatment progressed, people were of the opinion that basically what they were trying to do was use it as an ablative surgery. So they started to increase the intensity and the energy of the ultrasound device to try and burn out and destroy the vestibular hair cells. And histological sections showed it actually wasn't very good at destroying the end organs, the vestibular end organs, but it did provide relief. So they kept increasing the energy delivered without showing much different in behavioural outcomes, even though there was, in about 80% of cases, most patients did experience relief from vertigo. My thinking is that basically, I don't want to throw the baby out with the dishwater there. I think that really what was happening is that when they first started, they didn't have very intense ultrasound, and the effects that they were seeing were primarily born out of changes in the paracellular permeability of the membranous labyrinth. So we want to go back to investigating that to see if we can save the vestibular end organs, but use it as a technique to transiently increase the permeability of the membranous labyrinth. So to summarise that, with the particular research, we started using treatments to try and increase the outflow of end lymph and improve end lymphatic hydrops. We know that chemicals can manipulate the membranous labyrinth permeability. It's going to take us a while, though, to find the right types of chemicals. Fortunately, there are already sorts of chemicals that are used within otology, like benzyl alcohol, which are already applied to the inner ear of Meniere's sufferers, and in most sufferers provide some kind of improvement. And we want to make sure that these drugs, if they're going to increase the permeability of the membranous labyrinth, that they don't cause a permanent hearing loss. And our initial research suggests that it won't. You can have a transient hearing loss caused by an increase in permeability, but your hearing will recover within the space of an hour. So this idea that you can't manipulate and fool around with the membranous labyrinth permeability because you'll cause a really severe hearing loss just isn't true. You can use drugs that target the membranous labyrinth permeability. One of the key issues is still going to be that pharmacokinetics are a big hurdle. We need to work on ways of getting drugs towards the end lymphatic duct and end lymphatic sac, which is still where I believe the end lymph is being absorbed. I think maybe glycerol might be a trick that we could use to enhance the movement of drugs towards that region. And of course, I still think it's worth revisiting this issue to do with ultrasound. With today's modern understanding of how to use ultrasound, there's techniques that we use with microbubbles, etc., which mean that you can improve the effect of ultrasound on manipulating the paracellular permeability without causing the traumatizing effects that happen with larger intensities of ultrasound. Just finally, I want to go over a few projects that I'm not really talking about today, but there's other bits of research we're doing. We've done a couple of projects to do with vasopressin. We've done a little bit of this in the past. We still have more to do. Vasopressin is a hormone that regulates the aquaporin expression within the inner ear, and there's been some great research recently which has demonstrated that if you treat guinea pigs with vasopressin, you can actually induce severe spontaneous vertigo episodes, just like we see in Meniere sufferers. We've got students that have been working on the vestibular system. In particular, Chris Pastras is working on trying to understand what the vestibular efferent system is doing in the inner ear. The vestibular efferent system is a bunch of neurons that send signals from the brain down to the vestibular system, and we don't really know what they do, but we know that they have very strong effects on the peripheral vestibular system. And if we can understand what those neurons do, we might have a better understanding of all sorts of inner ear disorders. We're also trying to work on novel diagnostic techniques for the vestibular system, not just in guinea pigs, but also in humans. So we're doing a lot of research in that regard at the moment. I've also got the project going with Payal Mukherjee and Adrienne Mori, where Payal's been great at collaborating with all of her surgeons and herself been obtaining tissues from Meniere sufferers who are undergoing ablative surgeries. We now have a bank of several tissues from different Meniere sufferers, and we need to look at those tissues for changes between various proteins within those tissues compared to non-Meniere sufferers. And basically that's it that I wanted to touch on today. I do want to thank immensely the Meniere's Research Fund for their continued support and all of the committee members, but in particular Mr Bruce Kirkpatrick and Leo Tutt, who have both provided not only a huge amount of personal investment and time, but also financial investment into the fund. And I think Meniere sufferers are obviously eternally grateful to the fact that there are people out there, and within the Whirled Foundation as well, that dedicate so much of their time and effort and often finances to really trying to see an improvement in the lives of Meniere sufferers. I also need to thank Garnet Pass and Rodney Williams Memorial Foundation, who have funded both my research, Ian Kurthois's research and Payal Mukherjee's research in the last few years extensively. We're really lucky in the field of otology research to have an entity like the Garnet Pass Memorial Foundation. And obviously all the different collaborators and students that I've worked with over the last couple of years as well. And I'll finish it there. Thanks very much.
Good morning or good afternoon, ladies and gentlemen. And to repeat what Leo said and other speakers, thank you very much for coming along to support the Meniere's research and to hear what extraordinary things the research team and Daniel are doing. To me, it's a constantly uncovered revelation. My interest in Meniere's started because Juliet developed Meniere's disease in about 1998. And we were working with the support group in New South Wales then to find out what could be done about feeling better, stopping the attacks, etc. And that led to me suggesting that we ought to set up a research unit. At the time, the two leaders in the support group were a little sceptical about the possibilities. Malcolm and Anne Stewart said there is no cure. So we said, well, let's try and find out. The first thing I had to do was to find enough money to be able to finance the possibility of finding the appropriately qualified research doctor who we could appoint to head this research investigation, and that led to us finding Daniel. And from there, we had to get enough money to satisfy Professor Leader, who was then the Dean of the faculty, that we could actually afford to send him to America for 2 years and back here for a year. And the other thing that we had to do was then to have enough money to be able to find a laboratory and finance the equipment he would need to carry out his experimental research work. And the third thing was to find enough money to create an investment trust whose income, or we thought, would be ongoing and be able to continue to support the research work. However, from there, we had expected that the funds would come from this appeal, the annual appeal, which you all receive, and for which we're very grateful for your response. And secondly, from the various bodies like the Garnet Pass and Rodney Williams Foundation and the National Health and Medical Research Council and the Ramaciotti Research Fund. We've had a great deal of support, as Daniel mentioned, from Garnet Pass and Rodney Williams, and they have a background of considerable personal interest in what we're trying to do here. And the third area we hope to receive money from were bequests. And we have just received our first bequest in all these years. That's from Chris Woods, who did not have Meniere, had no interest in what we were doing to solve a problem that he suffered from, but he knew about it enough to decide that that was where he wanted to leave a large sum of money. And that was the third area from which we hope to be supported. Now, while we're very grateful for the support that you and so many others have given in response to our annual appeals, the research papers that have been presented by the speakers this morning are also the subject of our intense gratitude from the committee. That's Leo and me and Bill and the others, Ian, etc. Because without their hard work and the progress they're making, digging into what's going on in our heads, we would not be making the progress and the promise that is actually in front of us. One of the problems that both Leo and I face is that in my 91st year, I'm running out of time. And I keep saying to Daniel, get a move on, I won't be here. But he, as you see, it is a very detailed, complex problem to try and solve. The next challenge we're facing, and research is an ongoing business, is to employ a specialist to whom Daniel has referred, who will be appointed to explore a new field in molecular biology, and we expect that his work will help us to make some leapfrog advances in what we're trying to solve. In addition to that, we are now looking at the benefits which might flow from appointing a research coordinator, and that will require extra funding. In that respect, Juliet and I have decided to put in another 50,000 to kick it into play, but the play won't start. And don't clap me. We've got a long way to go. We need 370,000 or 390,000 before it can take off. You can't start these projects until you've got all the money. And when I paid for bringing a young Japanese out here to study for 3 years, the suggestion was that the money should go into the investment fund and we would be paid the interest off the fund. I said, no way. Either we get all the money into Yaz's hands, so he's financed for the years he's here, or we don't start at all. And that's the same with Chris Wood's 400,000, that we had to get the whole lot in one smack in order that Daniel could go ahead and employ our new researcher. And that's what we need to do for the balance of the 370,000 that we'll need for this new leap into a research coordinator. I'm sure you'll agree that we've all had a fascinating morning and know a hell of a lot more about what has been going on in this research laboratory. And I would like to thank all the chaps who've, and Pale, presented and Celine their papers this morning. And I think it's okay to call men and women chaps these days.